All right, this is a conference presentation for the Health and Education Group for Dr. Witt's EPS 580. We will start with Emily.
Okay, so I will be talking about the use of online or e-learning for genetic education. Next slide, please. So I'll just give a quick outline of what I'll be talking about. I'll just go through the rationale for doing this project, some of the background that people are already familiar with related to genetic education and online learning. I'll talk about the literature review, what is already published. I'll go through some research methods that I'll be using for a research project that I'm launching and what my hypothesis is for what's to come. Next slide. All right, so here's just a bit about the rationale for starting this project. So the genetics revolution is currently underway. Ever since the structure of the DNA was worked out, genetics has just been becoming increasingly prevalent all over the world, both in terms of medicine and in terms of daily life. However, despite the increased use of genetics, we have not seen a parallel increase in genetic education. So one of the ways that people have suggested trying to increase the amount of genetic education is by the use of e-learning or mobile learning for genetics. Next slide. So here's a little bit more background about the situation. So genetics is now spilling out of just health and medicine, and we're now using it in lots of places like law, so using it for forensic genetics, paternity testing, identity testing, etc. It's also being used in tech fields. For example, DNA is being researched as a way that information can be stored in very small quantities of space. We're using it recreationally, like through companies that do direct consumer testing, like 23andMe, and a variety of other situations. So the current state of genetic education, for the most part, is rather dismal. So in middle and high school, there's a minimal amount of genetic education. Once people decide to go on to postgraduate, graduate school, or medical school, they generally get 1, maybe 2 courses in genetics. And if they go into residency training, it's usually a total of less than 3 hours of genetic testing, genetic education in residency. Within the law sphere, people going into legal training, genetics is generally non-existent in terms of their educational training, despite the increased use of genetics in the field. So we know that educational changes are needed, but professionals are so busy that people have not yet tackled the situation and how we can increase genetic education. Next slide, please. So in the literature, there are a variety of studies that have been published addressing this gap in genetic education. So we know from the literature that e-learning for genetic education has in fact been implemented with success in the US and abroad, and some of the countries that have published reports on this include UK, Iran, Germany, among some other countries. And we can see from these results that there has been a significant increase in genomic knowledge among the groups that are using e-learning for genetic education. Next slide, please. So some of the topics that are being covered within e-learning for genetic education include basic genetics, how to things like central dogma, how genetics gets translated from DNA to RNA to protein, etc. Also differentiating genetics from genomics. People are covering the ethical, legal, and social implications of genetic testing, as well as specific genetic competencies and recommendations for specific fields, like for the field of medicine, pharmacogenomics, or law, etc. Next slide. There have been improvements in a variety of different areas for the people that are using these e-learning modules. We've seen an improvement in both knowledge and skills, self-efficacy. So in other words, people are being able to order genetic testing without having to rely on people who are geneticists by training. We've seen improvements in practice. Are they ordering the right test? Are they interpreting it correctly? As well as comfort level. How good do they feel about being able to explain the genetic test or represent the genetic test in court? Next slide. Also from the literature, there are some mandatory components of e-learning for genetic education that have been highlighted. For example, pre and post tests before and after the module are vital for being able to test, is there an actual difference between what people know before and after the test? And if not, if there are still gaps in knowledge at the end of the test, how can we then fix the modules to address those? We know that case studies are important. So, for example, creating stories in which there is a child who presents with a particular set of symptoms so that people can, module users can work through the knowledge that they've learned and putting it into actual practice. We also know from the literature that the modules have to be mandatory, or busy professionals just are not going to make the time to get these modules done. Next slide. Some benefits of online or e-learning for genetic education is that it can be personalized, so people can go at their own pace. The timing is also flexible. They can do it when they have time, maybe sitting on the bus on the way to work, so they do not have to all have the exact, they don't have to set aside time at the exact same time, so it works better into people's busy schedules. It can also reach a larger audience, which is great, particularly when some of the audience are around the world. It's cost effective. They can, using e-learning, we can simulate medical practices, for example, using things like virtual reality to try to create situations without putting extra cost into it. There's multimodality benefit to it as well. Different learning styles are incorporated in. It's collaborative. People can work together. That should be one. People get immediate feedback on questions that they're being asked, so they don't have to wait for an exam to be graded and get that feedback later when they have forgotten the question and no longer care. And it's also trackable for people to look at their progress, and for people who are creating the modules to also be able to track progress and what are education or knowledge gaps that still need to be addressed. Next slide. So for my research, the research project that I will be launching, I will be using research methods including interviews and surveys to speak with people to try to find out more about what they need, what information they would like to know about genetic testing. And I'll be using thematic coding to look at results and try to get some meaningful information from that. And for my particular research sample, I'll be looking specifically at physicians involved in healthcare and attorneys that use genetic testing in legal cases. Next slide. So my hypothesis is that people are going to want to know more about how to take a comprehensive family history that will tell them more information about whether they suspect something may or may not be genetic. I think that people will also want to know more about the different test types that are available to order. And they'll need to know things among the genetic test types. What is the scope? How good is the accuracy of the test? As well as the cost for their clients that they're ordering the test for, and some of the pros and cons, like turnaround time, for example. So this is what I think that people will be saying about it, but the study is still very much in its infancy, so I still have a long way to go. So that's just a brief overview of my upcoming research project. So I will turn it over to the next person.
All right. Scoot here, we'll have Taylor next. Okay.
Hi, everyone. My name is Taylor, and my research is on mental health in K through 12 schools in the Middle East. I chose this topic because it's actually something really personal to me right now. Working in the Middle East, I've had students who have been struggling with mental health issues, and I see that there's very little to no support in the schools for them. So I kind of wanted to do some research and see, what was going on in this field. So next slide, please. The purpose of my paper originally was to explore what mental health services and policies were available to students in a K through 12 setting in the Middle East, so teachers were better able to serve their students in this region. However, as my research developed, the purpose kind of changed, and I'll explain why later. So first I want to define some terms that I use in my research. So when I talk about the Middle East, I'm talking about the 17 countries and Western Asia as well as Egypt. And the majority of these people are Arabs, Turks, Persians, Kurds, and Azeris, although there are, of course, several minorities in this region as well. But for the purposes of my paper, I'm treating the Middle East as a cultural as well as geographical identity, in large part defined by the Islamic religion. When I talk about mental health, I'm referring to emotional, psychological, and social well-being. And in K-12 schools in the Middle East, this includes public and private schools. Private schools are extremely common and still subject to all of the same governmental regulations and oversights as public schools are. And then when I talk about stigma regarding mental health, I'm talking about the devaluing, disgracing, and disfavoring by the general public of individuals with mental illnesses. Next slide, please. So in my research, I found the history of mental health to be broken down into periods of time. So there's the pre-Islamic era, which is the area or the period from antiquity to the 7th century. So in this period, the ancient Egyptians believed that life and death was part of a continuous cycle. So special attention was given to the psychology and personality of the deceased. Many people in this time period believed that sicknesses were caused by angry gods, ghosts, or evil spirits. There were healers at this time that dealt with issues surrounding what we would now call mental health. They didn't back then. Their practices included everything from incubation, dream interpretation, herbal medicine, good luck charms or talismans such as the evil eye, and even psychotherapy. With the spread of Islam in the 7th to 13th century, it brought a new cultural identity for the whole region. There was progress in areas such as medicine and philosophy, but they were also, that was kind of overshadowed by this new shared cultural belief, such as sense of enjoyment, guilt, and self-esteem that were influenced by the new religion. And that eventually had a big effect on how mental health was perceived. There was a more holistic worldview at the time, which led to more multidisciplinary requirements for doctors, which did include some aspects of mental health. And the 13th to 19th century was kind of an age of enlightenment in the Middle East, but that was weakened by internal and external power struggles in the region. And not many new medical practices happened during that time. And at that time, it was common to just, restrict a mental health patient or chain them up. That was kind of how they were dealing with that in that time period. And then the 19th century to the present is when medical advances really took off in the region. They were heavily influenced by medical advances in the United States and Western Europe. And at this point, mental health was no longer like a speculation. It was treated as a serious medical topic that needed to be studied. Next slide, please. So through my research, the topic of stigma was really important. As mentioned before, historically, the Middle East has viewed mental health issues unfavorably due to cultural practices and beliefs. Although those beliefs softened over time, the stigma still exists here. Religion plays a large part in mental health stigma today as well. In Islam, it's widely believed that there's one God and that this God causes everything, including illnesses. It is seen by some as a connection to God, and others as sort of a test or punishment from Him. However, many in the community still see having a mental illness as shameful and are afraid that it will hurt their family's social status, which is something that's really important in this part of the world, is how their family is viewed. the stigma of mental health problems doesn't affect everyone in this region equally either. So intersectionality, which is the complex relationship that forms from having multiple identities coexisting, it can bring about the idea of double stigma. So for example, women in the Middle Eastern culture may feel double stigma when reporting about mental health issues due to the prejudices that they may already face as being a woman. So the perception can really stop people from wanting to even report about having mental health issues. And it can cause a huge burden on the people who do have those issues because they feel alone and they don't have as many services. So next slide, please. So current practices for mental health in the Middle East, statistically, the proportion of people who suffer from mental illnesses does not really vary that much from country to country or like regions of the world, including the Middle East. However, the services available do differ a lot. Of the 17 Middle Eastern countries, so far none of them have programs that were available and fully implemented. However, several of them are developing their programs. So this includes in schools as well. The World Health Organization has several publications and resolutions that call on these countries specifically to implement programs in their countries. And some of them do briefly mention implementing them in the school setting as well. Next slide, please. So in conclusion, there is actually little to no research available about services provided in K-12 schools, and that's kind of why the purpose of my research changed. There were little to no policies about mental health services in K through 12 schools, and it just shows that there's really nothing set in place yet. Special considerations. There are a few special considerations as I was researching that came up a lot. For example, something that needs to be studied further would be the refugee crisis, specifically in Syria, and how that's having an effect on mental health. And then as far as looking into the future, it's something that really does need to be implemented, as seen in the lack of research and the lack of policy as well. So it's something that really needs further research and further consideration in this area. Thank you.
All right, and we are on to Usa. All right, Daniel.
Thank you, guys.
Great.
My name is Daniel Kaitibi, and my topic is disease surveillance using mHealth applications in Sierra Leone, a tool for improved service delivery. My outline will basically be introduction, aim, problem, and significance, methodology, and conclusions. But within that, I will also talk briefly about some reviews that I looked at. Next slide, please. Next slide, please. Thank you. Introduction. Governments, I'll briefly read. Governments and institutions are faced with pressures to provide health services effectively, efficiently, and equitably, but this cannot be real without the use of information communication technology. mHealth basically stands for mobile-based or mobile-enhanced solutions that deliver health. In Sierra Leone, most cases, the diffusion of phones or handsets is so vast that you can get phones all over the country, but we are not making use of them. Next slide, please. Aim of this study, I haven't done it, but eventually when I do it, is to know the importance of mobile applications in the effective management of healthcare delivery in Sierra Leone. And I have 4 objectives. 1, to know the prevalence rate of communicable and non-communicable diseases. 2, to identify disease cases, events, and prepare for outbreaks of health concern. And then investigate and confirm suspected cases, outbreaks, or events. Analyze and interpret data on priority diseases and events. Next slide, please. A problem. Guys, we all know that we were struck by the dreadful Ebola virus, which basically killed a lot of people. Our health systems were not actually ready for such a major outbreak. And so we are caught off guard. We had to wait. We had to ask for help from a lot of international agencies. And so after the Ebola, government decided that they needed to strengthen their health systems. And so this research will focus on multi-disease approach to disease surveillance, really. That way, once we can identify diseases, then we can be able to find ways to fight them in the event they become an epidemic. Next slide, please. Sierra Leone covers an area of 71,740 kilometers square, with a population of 7 million. That's Statistics Sierra Leone. They did a census last year. They said we are just over 7 million. The health sector continues to suffer. Few functional hospitals in the country, a lot of peripheral health units, a lot of clinics, but most of these clinics, we only have the human resource. And even with the human resource, they don't have that capacity and ability to really work when there are outbreaks. I'll briefly just mention some of the uses of mHealth currently in Africa or in Sierra Leone. We have health call centers, we have health telephone lines, we have treatment compliance, use applications for treatment compliance, we have appointment reminders. Messages are sent to you via mobile phones to remind you that you need to come for appointments, or make sure you come tomorrow and see your doctor. Health promotion. During the Ebola, a lot of messages were sent. For instance, we have an NGO here called eHealth, basically, which did a whole lot for us during the Ebola outbreak. We have mobile telemedicine. We have public health emergencies. We have health surveys and surveillance, patient monitoring, patient records, raising awareness. My own research will basically look at health surveys and surveillance. Next slide, please. The significance of this study. Why do I think this study will be of importance to us in Sierra Leone? First things first, I will start my research in just 2 chiefdoms in the southern province of Sierra Leone. The Ebola virus started in the eastern province, just few blocks or few miles away from Bo, which is the second city of the country. And so one of my bases will be in Bo, and the other one will be in Mwamba district. What we know is at the end of the day, I expect that there will be increased access to new health technologies that leverage the power of mobile application, and for governments trying to cut the cost associated with operating a healthcare system, mHealth will help hospitals and health centers reduce paperwork. That is very important. Also, I'm hoping that this particular application will help our hospital staff to be able to easily and accurately detect outbreaks. Next slide, please. How am I going to do it? Methodology. I will employ the mHealth application. It's already there. It's just an application that I set up. We're going to use that. The thing is, we have a few handheld devices. We're going to set up a server room, give out handheld devices with the application installed on those devices. In those 2 chiefdoms, Bo and Mwamba districts, I'll have few hospitals that would use as pilot locations to collect our data. doctors, nurses, and community health officers will have the device, the handheld devices, and then they will basically use them to input the data. That data will be sent directly to our server, and from the server, I will then do some analysis. But also, backed by that, I will also do some interviews and focus group discussions. Yes, focus group discussion, because I want to know what really people are, going through in the health sector in the country, and what they did, what they went through during the Ebola, and how we can use this particular application to make sure that never ever happens again. Of course, I'm going to do quantitative and qualitative research would be used in my research. Next slide, please. It is hoped that at the end of the research, the health system will be strengthened and the country will be equipped to tackle an outbreak. Thank you very much.
All right, great. And all right, Musa, your turn.
Yeah. Hello, everyone. I'm Musa Aziz Yoki in Sierra Leone, and I'm looking at a topic on preventive and curative drug surveillance for infectious diseases using mobile health application. My research will be focusing on the southern part of the country. As you can look the map of Sierra Leone, that area is existing in the south in the town of Bo district and Moyamba district. And in looking at my outline, I have the introduction, the aim and objective, the problem and methodology, and that of the conclusion. Next slide, please. Looking at the introduction, Sierra Leone is almost like overwhelmed with diseases, as you can look at our live birth rate due to disease prevalence in the country, with so much death occurring almost per day. And this issue of death occurring regarding diseases cannot be the link with drugs, as drugs are almost taken by individuals, not based on prescriptions. So it's a serious concern that I want to investigate, looking at the issue of drugs and the prevalence of diseases as to whether people are complying with drug prescription from the appropriate health specialists. That's the point that I want to look at. Next slide, please. And looking at my aim and objective, I have the aim of looking at the preventive and curative drugs used for infectious diseases in that of Bo and Moyamba district, and basically saying that yes, diseases are on prevalence as a result of patients either not complying with the prescriptions being given to them, or looking at themselves taking some of the prescriptions that may be out of their communities, or maybe within the use of herbal drugs. So that's the situation that my aim is looking at. And within the objective set out, it's like I will now be looking at my Androids, the application, and my computer to monitor the surveillance of these drugs. We can look at the existing drugs prescribed by what you look at to be the WHO prescribed drugs for those diseases, and look at whether those drugs are the actual drugs prescribed by the doctors, and if those actual drugs prescribed by the doctors are the actual drugs also taken by the patient. So we identify substandard infectious and unsafe drugs in local market, and I can also be able to look at identify proper drug supplies inventory in the country. Then also have to look at the advanced solutions to illicit drugs peddling, as this is so common. Patients can walk into hospitals, or somebody that is not even sick can walk into a pharmacy and just request drug at will and can take it at will. So it's like almost a serious drug abuse, which may not be the actual drugs that can be used for a kind of illness existing at that time. Next slide, please. The problem, like we're looking at the problem and significance of it, is that we have the problem of a disease outbreak, and we also have the problem of looking at the drug, the wider drug use, meaning with no controls, with no checks and balances. Drugs are not being used based on prescriptions. So I'm looking at the problem of healthcare professionals and those of the greater incidence of a chronic disease existing, as to whether people are actually using the appropriate drugs, and that can be monitored with the use of mobile devices, Androids, and computers, so that we can get those records managed over time to look at, analyze it, and look at the actual outcome, matching either what we see now or some more revelations will emerge that will be much more significant than the problems that we're seeing at this moment. Next slide, please. And in looking at that method, we have 2 districts of coverage. That is the Bo district and that of the Moamba district, all existing in the southern end. And one thing we need to make very clear regarding the methodology that I'm using is that mobile phones are now almost on a very on a widespread use within the country because of a low-income country that relies so much on the use of mobiles to make requests from people out there in terms of their financial support. And that can be a channel that we can use, much as they'll be using their financial support means, will now be using it for their own health support in looking at the mobiles link up to the computers and our server, in looking at data collection, entering a given health facility. We use their health professionals who use their Androids, keep record, or we use the computer to keep record of the cost, the patient at that given moment, instead of the paper application they'll be using that can be lost over a very short period. Now we'll be using all of these Androids to have data bank, and that data bank will be of use to that community and the country at large. Next slide, please. In conclusion to all of it is, having looked at the widespread of mobile use within the country, and also with the abuse of drug by patients and the prescriptions given by doctors, and we don't really have what you call the pharmacies existing in healthcare facilities at the moment. Everybody's been asked to go by those prescriptions and buy the appropriate drugs in private pharmacies. In conclusion, we'll be looking at the reason or the effectiveness of those prescriptions being given as to whether patients are really complying with those prescriptions given to them, or they may be using some other prescriptions that has to work based on what they have within their community, or whether they'll be listening to their children, will be listening to their daddies or mommies, or whether they will be listening to their community elders in terms of which is appropriate to take instead of listening to the health professionals. That will be the conclusion in terms of our deliverables in this research. And also, we'll be looking at the effect. The research will reveal the importance or the dominance or the kind of result that we emerge with the use of Androids in terms of collecting data, and we'll be able to have a chunk of data available at the end of the day that we have policy analysis in terms of looking at the way forward in terms of health management system in the country. That's the note of it. And I thank you very much.
Great. Thank you, Musa.
Okay.
All right.
And I thank you so much, Jesse, for this kind of conference you've put together for all of us. It's so appreciative and a very good innovation from your part.
Oh, no problem. Thank you. Very good. Thank you, guys.
Yeah,
wonderful.
Right. Wonderful.
All right. Next, we have Danielle.
Hi, I'm Danielle Burgoon, and I chose to do some research on standards-based assessments and their effectiveness. And the reason that I decided to go this route was because I currently work at a school that's adopting a standards-based system. So next year, all the teachers need to develop standards-based assessments, and then the following year, the whole school's adopting a standards-based grading system, and then also a standards-based report card. And my original idea for my topic was to look at standards-based grading as a whole system, or standards-based education, I guess, as a system, and look into studies comparing it to the traditional system. But then I decided against that because my school is transitioning to this anyway, so whether or not the research supports that I'm doing it. So then I decided to look into, next slide, please. Next slide, please. Oh, sorry. No,
Okay.
back up. Yep, sorry, thank you. I decided to look at standards-based assessments effectiveness because I want to find out how they've been connected to student learning in order to help my research understand whether it's the assessments or the change in pedagogy that have had the effect. So ultimately, I wanted to look at, are standards-based assessments what's the most effective route, or is it that there's been this big shift in the way we are teaching our students, and that's been having this effect? Next slide, please. So what I ended up finding is that standards-based education is typically adopted as a whole system. So it's not just assessments, it's not just grading, it's not just report cards. It's this whole system that works together, and which makes it very challenging to look at things from just an assessments perspective or just an instruction perspective. There has been research to support both of these things, but I can't say that they're done secularly, that they're done separate from each other. Another thing that I've noticed in the research is that a lot of it goes beyond your typical classroom setting. There are many systems that go pre-K through post-secondary. Obviously, you don't have a ton of control over post-secondary because typically people are going out of, there's not really a district involved in that. Definitely pre-K through 12, that's where they're seeing the most, the best effect, I guess, where it is most effective. District-wide, so when you're going beyond teachers, beyond administration, going into the school board, having everyone involved, and really parent involvement seems to be a really critical piece. Having these parents sit down and look at these report cards together before they actually receive their child's report card, but looking at exemplars and teaching them what this is going to look like, how this is going to affect their kids' admission to university, really making sure the parents are, and at my school, I teach at a school in China, that's, I think, going to be our biggest, I don't want to say battle, but our biggest challenge is definitely going to be having our parents understanding our new system, because not only do our parents typically don't speak English or at least can't read the English, I think that their biggest buy-in to our school is that it's a great segue into American university. But I think the fear is that once we switch to this standards-based system, if their child's grades aren't where they want them to be at, that could impact our enrollment. So really making sure that the communication is there, but also, and the grades are accurately reflecting their child, which is the whole point of standards-based grading. So frequent informative assessments is also is something that research supports. So rather than waiting to do summative assessment, like big tests at the end of units, doing frequent check-ins with students throughout is something that the literature supports. Next slide, please. Using exemplars during instruction, so teaching the kids how their new work is going to be graded. Because ultimately, the shift is that you're no longer getting an A, B, C, or D. You're being assessed on the actual standard. So we're going to say how well you hit the standard or not. So really teaching the students how to use rubrics and looking at examples of good work, poor work, and teaching them how that's going to look, as well as giving them feedback. So again, a lot of this stuff is really tied into each other and reliant on each other. And then one big overarching theme is that a lot of, like I read a study about a school in New Zealand that the shift to standards-based assessments has forced a change in pedagogy. People didn't realize that, yes, when they adopted this idea of standards-based assessment, that there was going to be a change in the pedagogy, a change in the way they were teaching these students. And then even beyond the district, a change in policy, whether that's statewide, nationwide, that was a big overarching theme that I read about as well. So some suggestions for further research is that there's not actually a lot of research out there on our current traditional grading system. So it's hard to compare what we currently have to what we are going to have, or what people already have adopted. And I've noticed that it is challenging to study standards-based assessments separate from instruction, separate from grading, separate from the reporting. So that would be an area of research as well. And I think that's it. Thank you very much.
Very great. All right, we are continuing on with the health and education presentations. Let's skip through this person's. All right. And first up will be me. I'm Jason Hall. Hello, everyone. My topic, I titled my paper After the Bell, and I am studying the impact of extracurricular activities on student academic performance, health, and future success. Originally, I just had it on a little bit more general topic of just the impact of extracurricular activities on students. After getting into quickly in the research, there's a huge amount of research on this, so I definitely put it into sort of separated it down to those three categories: their actual academic performance, their overall health, and we'll get into different types of health, and then their future success, post high school and moving on. So some of the key words I used in my paper, the first is probably the most important to say, because I'll stop saying extracurricular activities and I'll just say ECAs. And what that refers to is a very large umbrella. Sports are a part of that. I'll break those down into team sports, individual sports, then the fine art world, which is kind of the performing arts and visual arts, and then academic success, stress, and future success are pretty standard. All right. So my rationale for researching this is, I wanted to know what the research has shown regarding the impact of extracurricular activities on students' health, academics, and future successes. It was kind of a big, important topic with me. Why is it an important topic? As an advocate for ECAs and an overall holistic education, I'm interested in finding out if there's a common correlation between the two. And what all the investigations has uncovered so far. I'm moving from teaching. I've taught for 20 years, both in the arts and in sports and physical education. I'm moving to be an athletic director in a different country. I'm currently in China, and I'll be moving to Dubai as an athletic director. So I thought to have a greater wealth of expertise in what the research has shown in this field. All right. So overall, a very strong correlation of ECAs with these things: student health, academic achievement, future success, and also having kind of higher career aspirations. That's something that I found in the research quite a bit. There's been proven results of obviously physical health, more with sports, also with arts as well. We generally see a larger increase in problem-solving skills that happen. And that's shown through like group work and sort of open type projects, higher level thinking in the classroom. We see there's some results of social and coping skills dealing with adverse conditions. And then obviously post high school, like getting into being a little bit more employable, having higher employability. I thought a great quote that I saw early on in my research was, "It's one of the most effective educational tools a high school can have." So with that quote, the question is knowing all of this information that we know, why are things still happening to our ECAs throughout the United States and around the world as well, to a degree? The question is, or maybe we don't really know this information that in my research has been so prevalent that I found that, do we all really know these actual scientific benefits of our extracurricular programs? So why is defunding occurring? Why are we abolishing ECA programs? Why does that keep happening throughout the United States? Do the parents, teachers, and admin, do they use ECAs as leverage for students to keep their grades up? So right now, I think it's about 16 states within the United States have what we call a no pass, no play policy, which means if you fall below a certain barrier, then you are ineligible to participate in these ECAs, which kind of seems counterintuitive, knowing that they actually help. So there's a lot of information on this. Funding dilemmas are a big thing with school districts, and often we see as the first sacrifice is this. We see athletic programs completely abolished or dwindled, and same thing with fine arts or performing arts. So in the gaps in the data, there are many. One of the largest ones that I've seen is that a lot of the studies lump all of these ECAs in together. And like I said before, in my keywords, I separated them out. Some studies started to actually break down in their data analysis, what sports specifically, whether it was like tennis or a volleyball team individual. There's a big difference in the data and what it shows. Performing arts and that versus clubs, tutor groups, study groups, things like that, after school academic groups. There's a big difference in data between those groups. So really there needs to be a lot more studies done on more specifics, like team sports, looking at that and its effect, that sort of thing. So the lack of specificity with the data is kind of one of the big gaps of what needs to happen. And this actually is self-admittedly admitted in a lot of the when you're reading their conclusions and sort of their evaluations of their own research, that they have lumped too many of the ECAs in together. And you look at the deviations, so the standard deviation between like a team sports all the way down to like a tutor group, it's huge. So their reliability is in question a little bit. So this also led to a little bit of other research about, we're seeing this also definitely in the United States, but also in international schools throughout the world, that students are, as soon as that bell rings after school, they have to be in something, and they just get involved in virtually everything, whether it's them or their parents doing it, thinking they need that for, college acceptance sort of thing. So you see them going from, the swimming pool in the morning to the afternoon to the track field, and then to band rehearsal, and then to dance rehearsal, and then go home for a piano lesson. Is this the best thing for our children? There's a lot of that out there. And, now we're seeing a lot of things about how, you're in the summertime, your child comes to you and says, I'm bored. And, maybe it's okay to allow children to be bored. That is kind of coming up in my research a little bit. And that's a little bit more of emerging research on that, about the power of boredom. That's very interesting. So an interesting idea I'll kind of summarize with is that the sheer abundance of these correlational studies, that alone is an indicator of its potential value that these activities hold for student development. There's just huge amounts of data showing this, and I think the sheer abundance of it alone should really help be a positive marker for how valuable they are. So higher grades, academic aspirations, lower substance abuse and depression, that came up a lot in research. Having a more positive attitude towards school is also something that's been happening. So I believe that's it. Thank you. All right, we'll skip to this one. And Marissa, you're up.
Okay, thank you. I'm going to be talking about taking back the land, school and community gardening interventions to reclaim health, food security, food sovereignty on American Indian reservations. Next slide, please. All right, so my topic that I just mentioned, we're looking at gardens, how prevalent they are on American Indian reservations, how they're implemented, how they're best implemented, and how they're adapted to the cultures of each tribe to try to kind of maximize their efficacy and their health outcomes. And in order to see if we could maybe replicate some of the successful programs and improve the ones that aren't maybe as successful, and then just disseminate them more widely throughout the United States. And if you kind of notice up in the right corner, we've got Sunrise, Accept This Offering. I'm definitely an outsider to this topic. I'm not enrolled in or affiliated with any tribe. And so I'm kind of going to use the words of Leslie Marmon Silko, who wrote the novel Ceremony, which, by the way, is an excellent novel that you should read immediately after watching this presentation. But I'm going to be using her words kind of to wrap my slides around to kind of give that conduit that literature is kind of the great empathy maker. And so we'll use her insider voice to kind of present my outsider research. So this is the way she ends or opens and closes her novel Ceremony, Sunrise. Next slide, please. Okay, so in order to kind of understand the context historically and otherwise of American Indian reservations and the state of them right now, We'll just kind of go through what we'll call lessons in loss in the different categories here of history, geography, economics, and health. Of course, historically, the land was taken. Programs like boarding schools, commodity foods, and the Dawes Act kind of broke up Native American tribes and separated them out, separated them from the land. Geographically, you kind of look at that middle picture there, that is very res. You know, if you've ever been on the res, you know that they're incredibly remote. They are food deserts because there are very few grocery stores available. Fresh produce has to travel a long way, and then it's usually going to end up in a gas station, bruised and expensive compared to all the cheaper foods that are sitting there. And so for the USDA to classify a food desert, most reservations fall under that classification because it also factors in median income, in which most reservations are also definitely on the lower scale of that. 3 of the poorest counties in the United States are in South Dakota, and they're reservation counties. And that holds true for many other counties in the United States, or many other reservation counties. These photos here are from the Pine Ridge Reservation in South Dakota, which with unemployment rates that vary from 85 to 95%, some crazy number like that. And this is true pretty much across the board for a lot of reservations. And so those food deserts really prevent that access to healthy foods. And the economy of the reservations prevent them from buying those healthy foods once they do reach the reservation. And so, of course, all of that lumps together to impact total health, which is also pretty poor. There's twice the national average of heart disease. Native Americans are also 2.3 times more likely to be diagnosed with diabetes. The infant mortality rate is high, and childhood obesity is also off the charts. American Indian 4-year-olds have an obesity prevalence rate of 31%, which is almost double any ethnic group coming behind that, if you could do a comparative of ethnic groups across the United States. Next slide, please. And so to combat this, to try to pull against all of these forces, the idea of food sovereignty has come about, and we define that as the rights of peoples to define their own food systems and regain access to traditional ways of life. And the recent political climate of the Obama administration has been really helpful toward that because of the Healthy Hunger-Free Kids Act, which appropriated lots of grant money toward communities, especially rural, poor communities, which reservations tend to be, and giving them money to start programs and initiatives and innovative ideas for preventing hunger and food insecurity, and gardens are one of those. Next slide, please. So these funding programs are also included with some private funding programs like the Native Seed Search Database and Seed Bank, and located in the Southwest, provides free seeds to enrolled tribe members and gives them workshops in how to grow and save these Southwestern hardy seeds. And we also have programs like Project Grow, which are more geared toward the Upper Plains Northern tribes, that provides free tilling and garden supplies and things like that. But anyway, under all of the auspices of these programs, we also have tribal colleges kind of leading the way, and K-12 schools starting all of these gardens in order to regain that food sovereignty. And here's just a few examples. There's just too many to profile all of them, but I thought I'd give you a few kind of success stories. The Cheyenne River Reservation had a program that was so popular that they were turning people away from their canning workshop. Their private gardens just increased 20-fold, where they had, after their first year of their garden, they had 56 new private home gardens that they tilled. The Yaqui youth in Arizona, that's a tribe there, they use their garden as a way to reach at-risk students. And so they had these students who had dropped out, who were trying to earn their GED and high school diplomas, and they used the garden as a tool to help reconnect them because they felt really disconnected from their heritage, as at-risk youth often do. And they used the elders in the community. They would learn traditional cultivation techniques from them. They would also take their traditional stories of plants and animals, and they would learn the traditional storytelling methods and use those to convey the story of the garden to the Head Start children in the tribe. And so it was just like this kind of regaining a connection to your community, and they reported a lot of success with that. The third one is the Sitting Bull College at the Standing Rock Sioux Reservation. That one wasn't necessarily a garden, it was a livestock management program that taught Lakota and Dakota members of the tribe to kind of give them another opportunity economically to raise bison sustainably, because that's a little bit more in line with their bison culture than the cultivation culture. But it still goes along with this idea of protecting your own foodways and maintaining your own food culture and reducing these food deserts. All right, next slide, please. So there's definitely best practices when it comes to this. Always the case in the research. The literature pretty consistently showed that if the tribes were the ones initiating this, especially if it was tribal colleges, then they would find a lot more success. Because of course, you know, they're not being imposed upon by an outside entity. Like so many of these other historical ideas like boarding schools and forcing tribes to cultivate land or whatnot. But when outside help is needed, or when outside groups want to either research or provide gardens, then there's definitely ways to go about it that are more successful than others. So I'll kind of tell a little story of the garden that failed, the garden that never was. So there was a researcher from SUNY Albany who went to a Northwestern tribe and tried to do this longitudinal, rigorous study about how a garden might affect the diabetes outcomes of this tribe. And so it was going to be several years long. She partnered with a funding group from the government that was going to give her all the, you know, the money and the tools needed. In year one, she established a pretty successful garden because she did everything right. You know, she tried to be culturally sensitive. She understood that patience is paramount on the res. If you've ever been to a reservation, there's something called res time, which means things get done when they get done. And she applied a holistic health approach as opposed to compartmentalizing. She also applied the communal approach. Like individual diabetes counseling doesn't really work a lot with tribes because it's more looking at how can the tribe get healthier versus the individual. And so community gardens really are beneficial in that way, because you can have communal spaces and communal health interventions that just make everybody get out more and exercise and eat healthier. She built relationships with the tribes, had all these steering committees and different key members of the tribe that were helping her out. The thing that made the garden crumble, though, is the funding agency was disrespectful to the tribe. So it was the government agency on the other end that displayed a general lack of respect, and they didn't want the tribe to have rights to their own. The tribe wanted the rights to disseminate publications, especially if those publications had sensitive tribal cultural material in them, which makes sense that they would want access to their own information, but the funding agency wasn't about to give them that, and so they pulled out of the study. It was deep into a year of research and all this work that went into it, so it just kind of underscores the importance that every entity involved needs to show this idea of mutual respect for something to work, and that kind of holds true for everything. And that also underscores something that I found continually in the research is that there is not a lot of studies like the one that Dr. Armstrong was doing in this garden that failed. There's a lot of implementation early. There's a lot of anecdotal evidence, like I've been showing, like the profiles, but there's hardly any longitudinal, large-scale, rigorous studies. And this goes true for just regular school gardens too. This isn't just tribal gardens. School gardens are kind of such a new concept to be added into the curriculum that there just hasn't been time to do long-term health outcome studies. And so the same holds true for these gardens. There's just there's just a lack of that evaluation to see, okay, does it decrease diabetes? Does it decrease obesity? Does it, all of those outcomes that we hope that it does or that we assume that it'll do just haven't been done yet. And so it's the area is definitely fruitful for more research. Next slide, please. And so basically that's the end of, we're looking at this idea of we need more research. But it's something that's very hopeful. It's the literature over and over again stated how this is a reclaiming of what was once theirs. And so we'll end again with Leslie Marmosoko's words, how she ended her book, which again, you need to go read. It's called Ceremony, Sunrise, Accept This Offering, Sunrise. The end.
All right. Thank you. Thank you. And Sarah, you're last to go.
Thank you very much. So I am Sarah Zatani, and my research topic was looking at the effect of nutrition on student academic performance. I really wanted to find out how a student's diet could be used to support them in the classroom, and what kind of items can be provided to students, and what kind of food offerings during lunch programs can be provided to these students, and see what kind of outcomes that those could provide for education. Next slide, please. So as far as some background information, obviously initiatives for healthy eating are becoming more and more common as a whole, and this especially manifests itself in school lunch programs. Ironically, politically in the US, President Donald Trump did just recently announce that they were going to lift some of the restrictions put in place, or some of the legal guidelines about lunches put in place by the Obama administration. I suppose we'll get to that in a little bit. But as a whole, this is the direction where a lot of school lunch programs and whatnot are moving. One important consideration, though, is that there is a really large discrepancy that's happening between schools around the world and even within the same countries, kind of we just saw with Marissa's presentation, within like on reservations compared to other areas in the United States. So there's definitely a large gap, but some schools and districts are struggling to feed their students enough of particular nutrients, while others then are providing meals with excess macronutrients, which we'll talk about in a second, but these can unfortunately cause obesity and other related health issues. So there's definitely kind of a broad spectrum here, and some of these actually kind of overtwine too. Let's talk about a couple key words though. First, when we're talking about a macronutrient, that has to do with the idea of the largest building blocks of nutrition. So your fats, your carbohydrates, and your proteins. Micronutrients, on the other hand, are more specific to vitamins and minerals. And these definitely much smaller amounts that you need on a daily basis, but still essential compounds. If you're not receiving enough of certain nutrients, especially the micronutrients is more common, there might be a deficiency. And these can over time cause health problems. Iron deficiency is one that I'll talk about today, as well as the concept of overnutrition, which is where people are getting too much of various either macro or micronutrients, and then it also has negative health effects. So that just is kind of a range there of some of the keywords. Next slide, please. So a lot of the studies definitely had kind of a global focus. So while I did focus more on the US, I wanted to acknowledge what the research suggested for explaining the effects of deficiencies, overnutrition, and then if there's not really much of an effect. So first, in China, a study found that as a whole, rural communities had lower graduation rates. While there could be confounding variables, one of the major differences, they noticed that a lot of these rural schools, many of the children had iron deficiencies or were anemic. And as an intervention, they provided supplements, iron supplements to students, and they did see an increase in student attendance and other positive behaviors. So that was an example where that iron deficiency maybe is linked to the graduation rate. As far as in the US, other literature reviews had looked at the data regarding specific vitamins and minerals, and they found that as a whole, when students do not receive, or when students have deficiencies or do not receive enough of certain micronutrients, it does often correlate with an increase in disruptive behavior. And likewise, they have found that when, again, like a multivitamin snack, some sort of supplement is provided, they did actually, in some cases, find a decrease in the disruptive behavior. As far as effects of overnutrition, in Santiago, Chile, there was a study done with 16-year-olds, and they found that students who had classified their diet as unhealthy or fair compared to those who had it classified as healthy, saw that they did worse and received lower scores on college admissions exams. In the United Arab Emirates, kind of an interesting look here, earlier on, they did struggle with iron deficiencies as well as stunted growth. But in more recent years, as there's been an increase in wealth in the area, we've also seen a really large spike in obesity. And in the classroom, some of these students as a whole have experienced lower energy in the classrooms as well as lower self-esteem. And then in the US, increased fast food consumption, such as like 5 to 7 meals of fast food per week, was linked to standardized test scores of about 10% lower in a few different US states. So that was kind of an interesting study as well. And then as far as a Danish study, they found that school absences kind of stayed the same even when they put forth a healthy eating program. So these just kind of sum up some of the different categories of data we found. But moving on to the next slide, a lot of the studies also really looked at school lunch policies, what's being done, and then also what people's concerns are moving forward. As far as some interventions, what's going on, obviously new standards, and within the US, I put this chart on here that kind of illustrates some of the changes that were made there, and I guess progress kind of as far as what is seeking healthier things, not as much data per se. As far as increased fruit and vegetable offerings, there was a study done in Norway in 2010 by Beer, Hilson, and Klepp, and they actually, the government provided free fruits and vegetables like once a day, like a student could choose a fruit or a vegetable once per day. And what was interesting, they did this for a long time and even did follow-up 3 years after the study, and they found that the program paid for itself, just first of all with health impacts, because the choices that the students were making, they were healthier because of these choices. And there was also a positive spillover effect that happened with parents. So overall, that was a really successful study by providing one piece of fruit or vegetable to all students, grades 1 through 10. As I mentioned a little bit before, providing multivitamins or snacks is also a way that schools can help kind of offset some of the deficiencies and also promote healthy eating or healthier options like fruits or vegetables. And then also forced restriction programs. In Finland, actually, they had pushed for a vegetarian day once a week. That was like a mandatory vegetarian day, and there was a lot of pushback to that. It wasn't, they were looking more so at the environmental perspective rather than the health impact, but there was a lot of pushback negatively at the beginning, but over time they saw increased compliance and especially among younger students, more positive outcomes. Concerns that are brought up regarding these school lunch policies: obviously, the cost is a major issue. Food access, we heard that a little bit with Marissa's presentation as well. Even if we determine, this is the healthiest diet, getting that diet or getting those foods to people is more challenging. And then also food waste is something that's brought up. Ironically, though, a study done just this year by Dr. Karen Cullen and Dr. Jana Dave, they actually determined that in several states in the U.S., fruit and vegetable waste did not actually change as a result of the new standards that were put in that required students to take a fruit or vegetable, etc. So that kind of challenges some of the ideas or notions that just because you put healthy food there doesn't mean that like the kids are just going to throw it away, kind of a thing. Next slide, please. Thank you. So as far as to kind of conclude here, some of the major gaps in data, one thing that's really challenging about this topic and likely many others, health is a very multifaceted thing. And so while a student's diet is definitely very important, there's a lot to be said about getting enough sleep and high quality sleep, physical activity, mental health, emotional health. And so it's really tough to know for sure that the interventions are specific to the actual foods that are being consumed. It's pretty challenging in some cases. Moreover, meals that are taking place outside of school are really tough to measure and monitor. So while there are good standards put in place to try to encourage healthy eating during the school day, when a student is off on their own or at the mercy of what is being served or what isn't being served for dinner or other situations, maybe even nothing's being served in cases of high poverty, that's really tough to, make sure students are getting enough of the right nutrients. Obviously, food access varies highly from country to country or even county to county, much smaller level. So that limits things. I have a little cartoon there for the food desert concept. And then finally, cultural attitudes and financial factors can make it a little bit more challenging. Just a quick example, large soda or pop companies in the US can get contracts where they'll contribute a certain amount of money and be able to have their products sold to students. Unfortunately, that does have negative health impacts, but it's tricky because if a school needs that funding and depends on that money, it kind of makes it, they're kind of in a tough place there. So those are some of the gaps, and further research, I think, could identify like more specific nutrients about that lead to increased academic performance, but there's really still a lot more that can be done. So that kind of concludes mine. Thank you, guys.
All right. Very good. I think that wraps it up.